But just mindful. Here we go.
Here we go. Well, ladies and gentlemen, boys and girls, welcome back to the All Things Aged Care Weekly Wrap-Up. As we say here, all for one and one for all things aged care. Unfortunately, our esteemed co-host and third musketeer, Anthony Newen, is down with the man flu today. Sorry to hear that, Ant, and we hope you're back up on your feet in no time. Ant is obviously the host of Aged Care. He's the founder of Aged Care Recruitment Experts and host of the Pioneers in Aged Care podcast. If you're looking for a clinical, management or executive position in aged care, or if you want to be on his podcast, let him know. Next up, we have our musketeer, Robert Cavino. Robert is the founder and CEO of Mirus Australia. He led the creation of technologies like Mirus Metrics and Care Minute Manager, and now the Mirus Plus, an AI-powered platform uniting software and data to streamline everything from admissions to compliance. You have to tell us more about that, Rob. And of course, we have myself, talking about myself. Rounding out our third musketeer is Owen Matheson. I'm a strategic connector and founder of Mission Critical. Love working with owners, boards and executives, and love connecting the right people, opportunities and capital to unlock growth. That's me. And of course, our very special guest for today is a leading figure, and we're lucky and blessed to have her in Australian health and aged care research, an honorary professor at the University of New South Wales, former foundation director of the AHSRI. Her expertise has shaped national policy, most notably through her design of the ANAC Aged Care Funding Model and her advisory work for the Aged Care Royal Commission. Currently, she balances high-impact research with strategic governance roles, serving as a non-executive director with New South Wales Meals on Wheels, the Older Women's Network New South Wales, and the National Suicide Prevention Office Advisory Board. Ladies and gentlemen, it gives us great pleasure to introduce and raise the roof for Kathy Eagar.
Well, Kathy, welcome. It's so good to have you on the show. And we have so many questions, and we're really looking forward to getting into this robust discussion and hearing so much of the fantastic work. But I guess before we jump into the actual meat of it, you've spent decades researching health and aged care and classification systems. But what drew you to this field and what keeps you motivated?
My story was simple in a way. I started life as a clinician. I was a psychologist, and then I got interested in health. And I was out at Fairfield Cabramatta, and I was the community psychologist responsible for health promotion and healthy communities right at the influx of the Indo-Chinese refugee population into Fairfield Cabramatta. Wow. And here was I, brand new graduate, dealing with people who'd been the victims of torture and trauma and all that sort of stuff, completely out of my depth. And I used to go into the health department and I used to say, you've got to do something. We need all these people. And in the end, they said, oh, look, if you think you know so much about it, come and be migrant health advisor for Western Sydney. And I was still in my 20s. And I said, yeah, of course I will, knowing nothing about it. But that started me. And so I went into migrant health and I commissioned a whole lot of research, particularly looking at the impact of torture and trauma on people. And that led to what's now START, the Service for Torture and Trauma Victims, and a number of other things. And I moved from there sideways into health management as Assistant Regional Director in Western Sydney. And then I went to the Illawarra. And after I'd been in that role for a while, where I was responsible for health planning and resource allocation, and people would come into my office every day almost and say, oh, we need this, this, and this. And I'd say, oh, what's the evidence for that? And they'd say, we don't have any evidence, but we know we need it. And in the end, I thought, I'm getting so frustrated by this. If there isn't any evidence, I need to actually build the evidence base. So that actually led me to change my career. And I went off and did a PhD in public health and health economics. And then I'd moved full-time into a research position, doing research into how the health system works and how to improve it. And then health led into disability and into aged care. And here we are today on a Friday.
That's it. Oh, here we are on a lovely Friday too. Well, I mean, you've had such an amazing career, and we've certainly followed it. And I've only been in industry, young 20 years, so just a couple decades. But I feel as an outsider, I'm still working on my Australian, but originally from Dayton, Ohio, and had a very different healthcare system over in America, which I'm sure you can, you've studied and seen the strengths and but also the weaknesses. And I guess what I loved about the Australian system and really socialized health, which is a format the Americans still don't really understand that greatly. I think it's really important, and I think it's upon reflection, the system we have is impeccable, and it really looks after so much of our society that really makes everything that I enjoy about Australia, turn over. But I mean, how important is it that aged care is continued to be built and governed, by Australians? And I know we've borrowed the best of elements, and you've led a lot of that fantastic research with the Ruck study and so forth. But what can we continue to learn from overseas, and what do we need to preserve and keep sovereign in Australia?
Yeah, well, if I go back to the American experience in health to start with, one of the things I've done is a lot of work internationally looking at what is a high-performing health system and what are the characteristics of them and what are the funding models that deliver the best health bang for the buck and the best outcomes. And one of the things we know from the American health system, which we did not apply to the Australian aged care system, is that privatised fee-for-service systems without proper gatekeeping and early primary care and early intervention inevitably cost more and deliver worse outcomes. You know that the American health system is the most expensive in the world, and Americans' health is, I think it's rated something like 15th or 20th in the world. We're right up the top. We get better bang for the buck, and Australians live longer. That's a pretty ultimate measure.
Yes,
you're right, we do.
Aged care. We've done two things differently to the rest of the world. One is most of the world does not make a distinction between health and aged care. Aged care is part of health care, and disability is too. And we have artificially created a whole aged care industry. And when you talk to older people, one of the things they tell you, they cannot distinguish their health needs and their aged care needs. All they know is their health conditions are triggering them to develop problems with mobility and ability to manage activities of daily living. And they will need someone who understands their health needs, their social needs, their aged care socialisation, functional abilities, that thinks about their housing and also thinks about their end of life care. And the reason I've been so vocal, speaking out against the reforms of the last 2 years, is that it does everything the evidence says not to do. It fragments everything. Supported home is about privatised fee-for-service. It doesn't deliver person-centred care, and it also doesn't deliver the best outcomes. It's more fragmented than ever.
If I may, I'd love to dig into your early days, the fact that you were a clinical researcher, you were involved in policy development, and you really had care as a priority at the centre of your priorities. And no doubt that shaped your approach and comments that you're making now, that you've been in the field, you've seen the good, bad and the ugly. What were some of those early learnings that have helped shape the way you think now, Kathy?
When I first moved into general health management, the thing that struck me, and which has not changed too much, was that diagnosis is not very useful as a concept. Right. And people think of healthcare as diagnosis-related care. Actually, acute care is diagnosis-related. You turn up in the emergency department and you've got a ruptured appendix and your diagnosis is appendectomy, and you need to do something about that. But beyond acute hospital episodes, diagnosis is not a very good predictor of need for care or the outcome of that care. And one of the things I did in my research post was set up 4 national outcome centres in measuring patient outcomes. And the first of those was AROC, the Australasian Rehabilitation Centre, and it's about measuring functional abilities, the ability to manage activities of daily living. And the second one was PEACOCK, and the PEACOCK is about measuring quality of life and symptoms, not diagnosis. When you die, it doesn't matter what your diagnosis is. It's all about quality of life, psychosocial issues and symptoms. Diagnosis doesn't even come into it. And the third one we set up was the National Persistent Pain Outcome Centre for people with chronic pain. Again, what the underlying cause is doesn't matter. It's actually how the psychosocial and physical management of that pain that matters. And then the last one I set up just a few years ago is PACOP, the Palliative Aged Care Outcomes Program, looking at how we address palliative care in aged care. You get people who are getting frailer and frailer, and no one actually says on Thursday they're living happily and on Friday they're going to be palliative care, because people can't see it. But a core part of residential care is to deliver end-of-life care. And we need, first of all, to get better at recognising when end-of-life's approaching. So I think that was a really big issue. And if I go right back to some work I did in the 90s, the government had decided to adopt diagnosis-related groups as the case mix classification and use it as the basis of funding the Australian healthcare system. And I started arguing with the Commonwealth, saying, you can't do that, you need something bigger. Their actual original intention was that acute care would be classified by DRG and everything else would be paid at the nursing home rate in every public hospital in the country. And that took me on a journey that led me to develop the first big alternative to DRGs, which is an American classification originally, which is that I developed the Australian National SNAP classifications, subacute and non-acute care. So the work we did then was very important because we actually defined what a subacute patient is. So that's rehabilitation, palliative care, complex psychogeriatric care, etc., and created a separate class, which is still the national standard now. So you introduced me and said I did ANAC, but it's actually I've done about 8 classifications across different countries, and building on the concept that what you've got to do is work out what drives the need for care, and whatever drives the need for care is the best predictor of the cost of that care.
Mm-hmm. And that's where a lot of the assessed care need models were really stemming from, with the work with ACFI and so forth. But I think if you could redesign, and this is a passion for, I know, for a number of the our organization, Amiris, but also from Peter Staples, who Owen and knows quite specifically, and where this is going to go is really part of the meat I wanted to get into today. But if you could redesign Australia's aged care data system and ecosystem from scratch, what would it look like? How different would it be to what we have right now? And I know you've laid a fantastic framework with ANAC, and I think it's a fantastic system. It brings accountability to also the taxpayer. It balances out the funding, maximization, and aged care is still one of the only, let's say, bulk bill type Medicare systems where you can actually be funded for activities that no longer may present with a resident or a patient, because they can re-able and we don't have to act on them as an industry, meaning they could be class 13 and they could be presenting as a 10, but we're still being funded. But at least we still have the care, direct care time and mandate that's in there. But I'm just curious, where are we with, I guess, in your mind, with that perfect ecosystem of our data system of aged care?
Yeah, when we developed the ANAC, we were really proud of it. The predictive power, the ability to predict cost, was actually better than the DRG system, which is pretty amazing. But when you develop case mix classifications, you have to hand them over to somebody else to do the annual costing study. and they never do it really in the way you want, and then they dumb down the weights, which is
Oh,
what's happening
absolutely.
now. And so people blame the classification, but we need to understand that it's the way that the costing's been done that's caused prices to come down.
The mechanism works. It's the costing. Yeah, absolutely. RVUs, and while the mechanism is there, it's sound. It's the.
I'm happy to explain technically why that's the case.
Please do, Kathy. Great for those that are at different stages of understanding the mechanics of it. Yeah.
The ANAC model's got two parts. One says there's a set of fixed costs to have the door open, and that's called the base care tariff. And that in that base care tariff is not just the fixed in a typical accounting sense, but it also includes things like the night staff. You've got you've got two people on for the night shift. Everybody could sleep through the night and nobody has individual time, or everybody could be up all night. Irrespective, having two staff is a fixed cost. So we looked at what is the fixed cost versus the variable cost based on the needs on a day-to-day basis of residents. Across the country, the fixed costs, we said we had a clinical advisory panels, and we said to them, what percentage of your costs do you think are fixed? And they said 50%. So we went off and did a really high quality study, and the answer was 51%. They knew. But importantly, the fixed costs vary by location and size, and also whether it's an Indigenous specific home. So the base care tariff, there's actually 8, and there's one for homeless homes, and there's one for remote Indigenous. And those ones are getting 80%, for example. I think the Indigenous one is from memory, in their base care tariff, and the activity component's less. But we did all that with a time and motion study where staff went around with a barcoder. And inevitably, once you've taken out your base care tariff and you get everybody to do a barcoder, you've got some unaccounted for time. We had a clinical panel and said, okay, about 25% of the cost, the staff time has not been accounted for. What do we do with that? And there was a unanimous agreement that it should be distributed between the residents in proportion to their direct care time, because that's the time that people are on the phone to relatives and they're doing all sorts of. But if they're not recording their time, it's because they're busy with individuals.
Yep.
So we maintain the integrity of the 50% split and distributed all the other time to all the other classes. When the costing was taken over by the pricing authority, it took the unaccounted for time and put it all in the base care tariff. Now, in doing so, it dumbed down, it flattened the differences between the classes. So the high-paying ones pay less and the low-paying ones pay more, which is actually not what you want to achieve in terms of incentivising care for high-need people. Anyway, that's just a side story about what happened to the ANAC and how if you do things like me and you develop things, you've got to hand them over to people who implement them, and they don't implement them in the way you like.
Yep. It must be frustrating for you to watch at the same time and seeing how, I use the term bastardized, things that are really fundamentally sound, and the structure and the ability to also adapt the mechanism to whatever our future healthcare models, costings can be done in the instrument. It's just the execution of that is what just for the audience who are listening to.
We also demonstrated that the classes were predictive of staff time. So therefore you should link instead of having standard amount of hours per day, link the staff time to the mix of class residents you've got in each class. And the staff time for allied health, for example, was different from personal care versus RNs. So we actually demonstrated that the people in the lower paying classes, though, have got really much higher allied health because they've got more capacity to gain independence, et cetera, et cetera. And in the high paying classes, there's much more use of RNs, that sort of thing. the funnel system is not sophisticated enough to reflect the real cost drivers. If I move on, though, when we developed ANAC, we really said to government there was two ways to develop a classification. One is the old ACFI style. You assess people, you add up the scores, and the highest the numbers, the bigger the class you get into. And the ANAC style is quite different in structure. It's a branching structure. And it says, what is the single most important factor that predicts your need for care? And it's how mobile you are. So the first ability to think about it as a classification algorithm or tree
is the Deming.
Yep, various levels of mobility. And around the world, everybody's moved away from additive because you end up with class 5. And in that class, you've got some people who can't walk and some people who are cognitively impaired, but they're very different from each other. You want classes to be as homogenous as possible because you want to be able to measure outcomes that are case mix adjusted as well. And this was a big change in this for aged care in Australia, but around the world, healthcare moved away from additive models last century, including in Australia, and we've been on branching models ever since. Come to a few years ago, and supported home gets announced, and supported home is based on the ACFI, the old ACFI that's been discredited and disbarred in the rest of the world. We've reinvented the ACFI, except we're now using it to pay fee for service, which is the worst payment model you can think of to drive what we're trying to change. And so we hear all these things about the algorithm has been validated. It hasn't been validated because there's no clinically sensible, there's no valid class. If I tell you your class 4, that doesn't mean anything. If I say here's a class of people who can't get around without assistance, who've got a whole lot of other problems like cognitive impairment and a risk of pressure injuries and bed sores, you know what that looks like.
And you know the costing and the impact on on it. Is Dr. Nicholas Hartland still evolving that, or where are we with the home care support at home? Because we do have a lot of support at home providers.
Told me that was a set that they were going ACFI, and I said, well, if that's the case, I don't want anything to do with it. So I pulled out at that point and had nothing to do with it, and it was because I basically had that view of if you want to get to Dublin, you don't start from here. The starting point for that work, in my opinion, was fundamentally flawed. But we got the support at home, and now they are using it really is robo-assess. Computer algorithm, and people are saying the classes make no sense. Well, people are getting allocated to the wrong funding bands. The government seems wedded, I think, is the fair thing to say about support at home. And
how is this? Can we ask you, Kathy, in terms of the level of consultation from government? I mean, obviously, you're someone who's devoted the bulk of your career life to exactly these issues and making sure that the empirical data is there, that it's practical. How many of yourself or your colleagues were consulted as the government went about developing the support at home framework?
At the very beginning, I was asked to be involved in the design of support at home. And then after it was made clear that it was not negotiable, there was no interest in pursuing a branching model, then I said this is going to be fundamentally flawed and it's going to end up in tears and I don't want to be associated with it.
Right. And
so I personally and the people in my team didn't have anything to do with it. The government set up a whole lot of advisory things and asked everybody what they wanted. But it's fair to say that in the aged care system, this is not people's bread and butter. It's a bit like asking me how we should design a new funding model for building roads. I would have no idea. All I know is I need to drive on the road.
That's right.
I want to be about the domain expert. So if we were to pause here for a moment, and you had that ideal scenario which Rob alluded to earlier with various points in your career, How would you assess and go about that process of determining the need if you had the opportunity to do it the way you would have suggested or advised?
There is a role for needs-based funding as well as output-based funding.
Yeah.
So if I tell you about, there's three sorts of funding models. There's cost-based funding, what you spent last year, plus or minus a bit. Yeah. That's the old block funding. You've got output-based funding, counting widgets or hours in supported home. And then you've got need. What's the need of the people who live in this region? And that can we quantify that in a funding model? I think I don't share the view that we need that one size fits all in aged care. I'm very keen, and I've argued this week at the Senate, rolling CHSP into supported home would be absolutely a disaster. Yeah. They don't fit. Grant funding and fee for service are oil and water. And I made the comment at the Royal Commission, the third rule of program design is you can't, program integration is you can't integrate a square peg in a round hole. Okay. I am very keen to see CHSP remain as a separate program. There's 850,000 people in it. There's only 300,000 now in supported home. And the move to pick up the principles, but not the technical detail of the ANAC, but recognise that there's a set of fixed costs to have to run a service, and then there are variable costs for the actual care you deliver. And I'm very keen that CHSP moves from block funding to what's called a price and volume contract that says where you get your block funding up, your fixed costs up front, you get your base care tariff up front, and then you've got activity, and we're not paying you for every hour of service. We're entering into a contract that says your job is to deliver 1,000 units of activity plus or minus 10%.
Yep.
If you're 10% on each side of that, between 900 and 1,100, we square off for the year. If it's less than 900 you deliver, then that we will reduce your budget for the following year because you clearly don't need it. And if it's over 1,100, we'll fund you more to take into account that you're treating more people or servicing more people or delivering more meals or whatever the unit of measurement is.
Yep. What's much more simplified and straightforward, predictable too. But I just wanted to take also the conversation quickly into the tech side too before we go to the backstage audience. So this is something dear to me too, Kathy. But I'd like to hear your views on it. But I've come to Australia about 20 years ago from IBM, and I know the power of information data, but also I know the importance of sovereign controlled application systems and data that we use to govern it. And I'm seeing a crisis happening in front of us and it's continuing to pick up with the advent of replits and vibe coding abilities that you can build applications and, bring them into the country and start to distort really what's important. And at the end of the day, our system is a division of government. It needs to be governed by Australia rather than licensed from offshore vendors. But I guess, Mom, I've seen also the other side where I spent the last 18 months up until last November, I gave it up, trying to raise capital. And I know the investment strategy that's being played upon our country, which is buy critical assets, buy sovereign data sources. Then you have the country and the government buy whatever you want to note it as, and we are then setting us up for failure. But now we're also setting our clinicians up for failure and doing harm to residents, where we have still a large volume of shift working RNs and clinicians that may jump between 6, 7, 8, 9 facilities and different providers each week. And we are throwing at them variations of different applications and systems to do one thing for one set of standards in this country. And residents are now being put at harm because I don't know how to enter in an S8 correctly, or I can't interpret what that means, so I double dose the resident. And these are situations playing out today. where do you think and how important is that the aged care platforms are built and remain governed in Australia rather than licensed overseas? And what should we be doing now? Because this is something that I'm starting to now advocate and lobby, because government is not following what I thought was the strategy, which was Australia and first and invested technologies on critical infrastructure such as our healthcare services.
Well, yeah, look, you're making some really good points.
Mm-hmm.
The governance of the Australian aged care system over the last 10 years at least, and I could go back further, but essentially in this century has been woeful, because the government keeps thinking about age, that their role is that it's a funding entitlement. There's not a lot of they don't really distinguish between delivering an aged care service and giving somebody a pension. And it's all about eligibility and not about needs. You know, the new integrated assessment tool is what level of eligibility have you got for funding, rather than what are your needs. And CHSP has been so neglected that there is still no national minimum data set. And then it turns around and says, oh, CHSP, what do they do? We don't know what they do. Before data sovereignty really needs to come back to basics of what do we need data for and who's going to use it. When we set up AROC, the Australasian Rehabilitation Outcome Centre, 23 years ago now, I think, clinicians across Australia and New Zealand in rehab all agreed that they were going to collect the one functional measure called the functional independence measure. And it was optional, but it was optional. But we achieved 100% buy-in in every public and private rehabilitation service in Australia and New Zealand.
But what about the applications we have now? We have over 31 different care management applications to document residential aged care and home care, and it's growing. And the money that groups, taxpayer-funded resources, including the capital and the RAD pools that these businesses have, which Treasury still underwrites and whinges about with the RAD, underwriting for the tune of 35 plus billion, and then that's under review by the task force. But I think we have something fundamentally we're missing here as a country and as a sovereign, sector.
Absolutely.
And we know what government wants. They want to see more transparency and data out of the other side. But why are we making it so hard for everyone? And it's the nurses and the residents now and the taxpayers that are starting to really suffer. And that's where I kind of really want us, have a hard conversation with the, Sam Ray and really those who are, need to be aware of what's happening out there in front of us. And I think if you go to the national conference this year, you'll see a conference that has grown from really was the back of Jupiter's casino about 20 years ago of about 6 vendors to now something that is in excess of over 100 different vendors, all vying for what they read and investment theses from overseas private equity, trying to move in, not for the purpose of making healthcare and aged care better, but for really returning to shareholders and controlling data sets that will power much bigger AI models and ecosystems that are mostly going to benefit overseas. And I guess because I'm in the data side.
Yeah, I mean, the obvious response I'm going to make is that this reflects a fundamental failure of governance by the Commonwealth. And if you look at how far the states and territories have got, they've got economies of scale, but they have been able to roll out homegrown, take international systems or grow their own and roll it out with consistency en masse. And health is decades ahead of aged care, and that's because too much focus. The Commonwealth doesn't have any background. I mean, if you're not an Australian background, the Commonwealth only ever got into human service delivery at the end of the Second World War. The states and territories had already been delivering services for 150 years. Commonwealth is still the new kid on the block. They still see it as they cannot distinguish mostly between what's a financial entitlement and what is a complex human service delivery system that they need to govern, nurture and grow.
Yeah, that makes a very good point. I mean, I think about it in the context that we struggled to lay a common railway gauge from north to south, so let alone having a common framework or system. Maybe it's too big of an ask, but I'd love to continue this conversation as well much later. But I think, Owen, you've got a couple people that want to come on and ask Kathy some one-to-one questions. Kathy, you're very popular today on this Friday afternoon.
Yes, you are. And we want to thank everyone in our growing community of purpose out there, all things aged care. We really want to hear your voice. And now it's that time of the show where we have our open mic and we invite everyone to come in and share their views on what is a very an unfolding landscape right now. And obviously to ask Kathy about her journey and who have we got? Daniel Zelli, I believe. Is that right, Daniel?
Correct.
Daniel, welcome to the show. We'd love to hear where you're from and why you're passionate about aged care and what you'd like to ask Kathy.
Yeah, so I'm a recent entry into the aged care space. I have a long history in C-suite experience and in particular technology experience. And been over in America, came back to Australia the last 2 years and worked in predominantly aged care. And right at a good time because, of the push for changes in technology and things like that. And working in it for 2 years, worked across 19 different aged care boards as a virtual CTO.
Wow, in 2 years. That's fantastic exposure.
Yeah, exactly. Concurrently. Working in different sort of organizations, national sort of role on behalf of an IT consultancy. I was really interested in some of the comments that were made around the premature rollout of Anakin and the ability for, aged care providers to cope. I feel like there's great pressure on aged care executives, and what concerns me after being, I'm really new, so like, who am I to say? I'm just observing, but what I've seen is a lot of flurry and pressure on executive teams to make decisions, big capital decisions around IT, without even knowing what they're doing. That's my concern.
It blows my mind. Yes, I know exactly what you're saying. I mean, I can't believe what some of these businesses are spending on even just license fees alone. And I think back to what we could have had, and Kathy made some really good points in there too. When Kathy, I want you to extend that, this just framing it for you and the audience as well. But I think I'd be keen to also just share some of those experiences there, because a lot of that is really what we're starting to see play out and impact sustainability of these businesses. It's driving some of the roll-up. It's also driving some of the government requirements to take on the RAD pool and take ownership of it, because they've effectively spent so much of that capital in some of the wider infrastructure investments that I don't know if they were just sold or hoodwinked or whatever it may be. From an IT consultancy side, you would be faced with that, and I'm glad you are on 19 boards, because hopefully you bring that that sense of that board and those understandings, because technology has been something that has been, I think, a low adoption industry. So, Kathy, please weigh in on that this discussion, because I think that's really great points.
Yeah, I think technology. Well, I think the change issue. The problem that happened in 2024-25 was not that the pace of change was too fast, but it was on and off again, and the rules were changing and people were getting new rules every day. I've evaluated big change programs, and the closure of a hospital at one point and the opening of another one.
Oh, wow.
And the long drawn out change is awful, and really it does more damage to staff and management than the quick change. But the quick change has to be very well planned in advance. Everything's going to happen on this day and boom, the system goes live. That is the most effective way to do change. but it requires good planning and certainty.
Absolutely.
And I mean, the government made exactly the right decision to delay the implementation of the Act and support at home until the 1st of November, because it was never going to be ready in June, but it should never have accepted June, because like me and others were saying that we're not going to be ready. The IT is not going to be ready, nothing. Staff are not ready. We're still getting new rules every day, months later. So I don't think we should be too concerned about the pace of change. The issue is about creating certainty for staff, for older people, for managers, and for people making investment decisions. And the sector has not had that.
Well, Daniel, I think also from the government side as well, for those who are in educator, you need to deal with these direct systems such as the GPMS, which is our government platform. It's a Salesforce system. Yeah, we spent over 300 million on, and I'm hearing now it's up to over 800 million on that ecosystem, and we're still, I would say, are we better off than what we had? I don't know. I'm not on that side of it, but I see that's just part of the entire equation here that I think really needs to be more transparent on both sides. But I think from an industry point of view, I think we need standardization. I think having so much of this is now putting a lot of people at risk. It's confusing the boards. It's confusing. I mean, as a board member, your job is to look and govern the risks that the business is trying to take, and to add these technical decisions is a very hard. Because I've sat on also aged care boards. I'm thinking of some of the personas on there. It's hard for that type of board member to be out amongst all of those aged care boards across Australia. There's a lot of accountants, there's a lot of great nurses and other quality, very strong quality and lawyers, but I think technology has been certainly a void. And I think now we're at a point where we really have to have a look in the mirror and strong discussion about where do we want to lead this sector, because if it continues the way it's going, especially with how AI is spinning up more platforms and things, it's just continuing to dilute and confuse and create something that is so standardized. Like we're all working to the same standards and ANAC model and direct care time. Why is there now so much variation and so much waste and time and resources being put into this very technology ecosystem we have?
Look, that's a really important point. But I also think let's be careful we don't have the tail, wagging the dog here. Technology should not be driving the system changes. The system changes should be driven by human need, by and technology.
Why is there so much variation and so much waste and time and resources being put into?
I'm getting it fixed. Yeah. So I just really want to say, let's not take the whole conversation up on the technology and the need for standard data sets. That should be the result of knowing what we want to achieve, and I don't think we do.
Good points.
Interesting. So we've got some another big structural sort of question from Karina Peace, who's sitting backstage. Karina, would you like to join us?
Sure. Hi, Kathy. How are you?
Great to have you on board. Karina, how are you? Karina was one of our experts when we developed the ANAC.
Oh, yes. Fantastic.
And taking up from that, and you're right, Kathy, we're really proud on the model of ANAC that we did develop, and the problem has been in implementation, and only just recently calculated the difference of the ANAC NWOW from when we first put it in to currently, and class 13 has reduced in the last 2 years by $85 per person per day. So the perverse incentive the department has on changing the weights and changing the costing annually to suit themselves is now they're the ones gaming the system, where before they were accusing providers with ACFI in gaming the system. In that, I also note the alignment of the department to align community care, residential aged care and NDIS into the one system or one platform to create efficiencies for them. How far do you think that will go? And do you think it will go to the point that we will align with private hospitals and private health insurance will pay for aged care?
Yeah, okay. Good questions. On the first one, the problem is actually a technology mistake. I mean, it was a policy decision made by IACFA that unallocated time should go to the base care tariff. So the highest paying class actually does get more of that unallocated time when you talk to experts, and you were one of the experts that did that. But when the study used a different sort of technology, and a 30% or more of the time was unallocated, and they put it all in the base care tariff. Now, no wonder the relativities between the top class and the bottom class were going to come down when you've loaded unallocated time. So it's a policy choice, but it also created the wrong incentives because it's overpaying for the low need people and underpaying for the high need people, which is exactly what we don't want it to do. Sitting back to the bigger picture, a lot of the reforms we're dealing with were not designed in health. They were designed in central agencies and by a group who started this work really back in the Morrison government era. And it was all going to be private for profit, fee for service, thinking, and at that point, when they started this work and decided to do supported home, NDIS, they were all talking about, was a brilliant system, and they were really very keen that supported home be an NDIS for old people, except they'd have to pay a lot for the privilege. And a lot of the principles of supported home are NDIS. And as the NDIS started to go pear-shaped, government started to write more and more rules to stop supported home going like the NDIS. So supported home's now got 700 or 800 pages of rules to stop it going like the NDIS. And it really misses the point that just like you can't pay for rehabilitation using DRGs, you know, in health we have 5 national classifications for different types of services. We have one for emergency departments, one for subacute, one for acute. We understand that. We've got the MBS and PBS. There is this really dumb approach of trying to dumb it down and fit everybody, you know, square pegs into round holes. And it is absolutely driven by a very central agency neoliberal view that their job is to protect taxpayers from providers and consumers who are greedily trying to get their noses in the trough and get an unfair share of the money. And that's because there's not enough focus on outcomes for older people. We're not measuring them. In rehabilitation, we know the outcomes for every person in Australia and New Zealand using the same assessment tools. In palliative care, we've got the Peacock tools, the palliative. We know the outcomes. We know that for every single patient. And we can tell if they're starting to decline and who's improving, and we can benchmark. But if all you measure is cost and widgets, then that says that's all you value.
Yeah, very true. The second question that I might quickly just raise is that in the Aged Care Funding Reform Committee, one of our most recent discussions, and I'm pretty sure I can talk about this, is the use of technology in creating efficiencies in residential aged care facilities. That it wasn't the department originally thought it was a productivity issue, but it's more of an efficiency issue with the burden of the documentation and the burden of the regulatory spreadsheets that the government have costed millions of dollars for them to develop an Excel spreadsheet, and that you have to repeat 10 times every quarter or every month to submit information to the department. And very clearly, they did not understand that the providers' priorities at the minute are not to pay or use the little money that they have with over 50% being non-profitable, to pay for development of IT systems, that it should be the other way around. The IT systems should be developed and come to us, just like every other industry. But for some reason, that's not happening. Yeah,
it's penny wise, pound stupid, because ultimately the Commonwealth has to build the price of the IT. Providers have to build the price of their IT costs into that cost into their price. It really makes no sense, and that's what I mean about when you don't actually design the rules to fit the model you're working in. What happened in America when they introduced mandated staff time is that they found out that providers were cheating, funnily enough, on what they were reporting, and they mandated that providers actually had to send a copy of their payroll data, and it was up to the centre to actually get that into a standardised format for reporting. And that was the only way they got accurate data, was to take it from the system you already have. You have to send a perfect shadow of it, but then it was up to the centre to do that for the whole country. And they managed to do it in America. We could easily do it in Australia, or even more sensibly, the government could invest in systems that are required to be used by anyone receiving a subsidy.
agree.
It's interesting. Karina, thank you so much for those questions. I think it's very, I think we are at a point to continue this conversation and this discussion with some of the broader, government influencers, because I see it too out there in the field, and I would imagine with some of the boards being presented with these proposals to spend millions upon millions of really what should be going, to, as Kathy said, to the core purpose, which is, we've lost sometimes focus of the resident. And also I feel we need to continue the co-designing of working what our system is, because our system is very unique. I mean, I've studied health systems. My mom was a school teacher in the States and grew up in Ohio, and we were benefits of the HMO type of systems. So, that was probably as similar as you could get if you were lucky enough to be part of an HMO, but it was one segment of a healthcare system in America that we now have as a national offering across all Australians here, and that's quite unique. And I think we really need to look at what's happening beyond the aged care settings. But it is an area where I don't think we've had as much of the specialties of that type of discussion. And I don't think any of this from memory was really covered that much in the Royal Commission, Kathy. I mean, there was a lot of the dignity and the resident outcomes, but I'm now seeing how we are putting residents at risk because of some of these variations that we're imposing upon our largely migrant workforce, transient workforces that are looking after a lot of aging Australians across the country.
Now, again, it's not a technology IT problem, it's a culture problem.
Yeah.
And we keep, culture eats strategy every day, and we do have a problem of culture at both levels, I think. We have a problem of culture at the Commonwealth level, and, the Commonwealth only governs two systems, and it doesn't do either very well, and that's the NDIS and the aged care.
It's so true.
And, we imagine if the only way you could get into a school was to go through a My School gateway. Yeah. Every other complex system in Australia is decentralised to the regional level, and we accept that what's going to work in Wollongong won't work in Alice Springs. But in the way that the Commonwealth has rolled out aged care is the assumption that it's one national gate. That's why there's 300,000 people sitting on various wait lists. But the only way, to answer an earlier question, the only way you could fix aged care now is to actually decentralise it and regionalise it for exactly the same reason that the states and territories, we've got health authorities and regional departments, regional offices of education departments, and we have PHNs. And And I think whilst ever the Commonwealth tries to run it centrally, the bureaucracy is going to get bigger and bigger and bigger and more isolated from reality. And providers and consumers are going to be so far away from their thinking that the twain will never meet.
Well, we have Kim Davis joins us here in Townsville. Kim's with a support at home care provider. So she brings a great voice into these discussions from that part of the landscape. Kim, let me wrap us up with some of the final questions for Kathy today.
Hi, guys. Pleasure to virtually meet you, Kathy. I'm a big fan of yours on LinkedIn, and thank you so much for advocating for the providers in the sector and ultimately our clients. I think what you say is just spot on from a small provider's perspective. I read your article this morning talking about, the government thinks that there's a lot of cashed up boomers and elderly people who can well afford their aged care. And, I spent the last 3 days in the eastern suburbs of Sydney in Watsons Bay and Vaucluse, and I tell you what, there's a lot of cashed up people in those areas. There's not a lot of new home buyers, that's for sure. But sorry.
Yeah, there absolutely are. And you saw my comments that it's about the inequity within the boomers. Those of us who are cashed up, our children are going to inherit a lot of capital and they'll be fine too. This is not an intergenerational issue as much as an inequity issue within the generation.
Absolutely, yeah. And I think that's sort of where I'm going with the comment. I live in Townsville and it's certainly not the eastern suburbs of Sydney. And, I've been in aged care long enough that I've seen a wide range of people and of different means. And I think the system that's been set up at the moment it's just not fair and it's not working. And I've been a fan of the levy concept, the Medicare style levy concept for some time, pretty much since before the new model was announced. So I really think that you're spot on with that advice, and I hope the government's listening to you.
When the government first put out its fees being quantitative, I tried to model how they got that result.
Yeah.
And the only way I could get close to it is to model based on the assumption that they define aged care as everybody over 65. So if you go back, self-funded super, compulsory super was introduced in the 1990s, 30 years ago. The current older population predate that. When I looked at, so then I wrote to the Australian Association of Superannuants and I asked them for their data and they gave it to me. And at age 65, only 31% of people retiring in their, 60 to 70 are on a pension. And by age 80, the average time that people need aged care, 75% of people are on a pension, and it goes up to 80% in the next age group. Yeah. And we need to understand that whilst there, and that the amount of, there's only 15% of superannuants that have got more than 100,000 in super.
Yeah, it's not much.
That pays for about 9 months of residential care. You're doing much better in this idea that there's millions of boomers out there and they've all got millions to spend on aged care is just not true. And we haven't seen anybody be honest enough about what the intentions are with the family home. I think politically that's too much of a hot potato.
Yeah.
But
and you can't
family home.
Yeah, you can't eat that family home either. So, there's even if you're self-funded, you're still on fairly limited means for a hell of a lot of people. So, when you're looking at, potentially a couple of $100 a week out of a very limited budget, that's a lot of money.
Isn't it?
Yeah. The other thing that I like that you've said today, and it's certainly I've mentioned this a few times on LinkedIn, I don't believe there is a one-size-fits-all Australia-wide model that's going to work for aged care. And I'm old school under the hack model and, state-run systems. And we did it well. We did, sure, there was room for improvement, but we were small providers who knew our community. We knew our clients. It was truly person-centered care back then. And in the, and providers cooperated to make sure that no one missed out on services. But, the government in their wisdom brought in my aged care and home care packages, and we are where we are now. So I think it's too late to go back. I don't know. What are your thoughts?
Well,
Do you think
certainly
that will ever happen?
we are advocating very hard for CHSP to remain as a separate program and be grant funded with a base care tariff to cover the fixed cost and a price and volume contract to cover activity. We have established a new CHSP alliance, and we've invited 8 prominent individuals and 60 organisations to join in the last few weeks. And 30 of them have already joined, and we have developed a position that we were about to be advocating to government. I gave evidence, not on behalf of the alliance, but around that in the evidence I gave the other day. We have to be very clear to see that CHSP going forward needs to be the primary care level of the aged care system. And just like it would be totally nuts to think we're going to save money in health by abolishing the GPs and primary care nurses, it is madness to abolish CHSP, that we need to be redeveloping it and funding it and resourcing it to do the primary care level of the aged care system, supported home for those who wish to opt in to an individualised funding model at the secondary tier, and residential care as a tertiary. And we will not survive. Think about 9 years' time, 2 million people over 80, and then some younger ones too. If anybody thinks we have the capacity to have individualised assessment and budgets for 1.5 million Australians, they've got rocks in their heads.
And the demographic will be different as well,
So if I may, there were a couple of people that really wanted to get some questions in, Kathy. Dr. Johari Amar said, do you think the department will be able to achieve person-centred care over time? I just wanted to give her a voice there.
That's an easy one. No.
Right. I thought that would be pretty simple. And then Sue Watts, she's an aged care and dementia advocate. She said NDIS do not pay co-contributions and do not have to have a provider self-managed supported home under supported homes being eroded.
That's what I said. The original idea for supported home was that it would be based on NDIS, and then when NDIS started going pear-shaped, they started changing and introducing rules to stop it going like NDIS, and that was about co-contributions, no self-management. Nobody should believe that there is any commitment in supported home to choice and control for older people. It is a pure myth. And that is because government are so fearful about replicating the cost blowouts in the NDIS. And Judith, I've just seen
we've also got a
wrong time.
I don't know if you can see that, Kathy. There's a last response from Judith. Are you a colleague of Judith Leeson, no doubt? She said, I'm so disappointed that this session was advertised from 4 to 5 p.m. and I had registered and planned for this time. We're so sorry too, Judith. We would have loved to have you on. If you are there, please jump in. I know we've gone over time, but we do our best to make sure everyone is heard. Kim, we thank you for jumping in because you're always there on the front line trying to make sure that the voice of your clients is heard. We value your contributions. Judith, if you're there, please jump in. Is there a question just before Kathy goes? Thanks. Best to you and in your team. Judith, is there a question from you before we go? Yes. Okay. From Judith, Kathy, what about the right-based system stated as art of supported home?
Yeah, when the rhetoric around supported home was that this was going to be a demand-driven system based on choice and control. The experience since November is that it's anything but. And I think that's important. One of the recommendations from the Royal Commission that the government didn't accept was that it should be a demand-driven system, that if you need it, you automatically get it. We now have 200,000 to 300,000 people on the supported home package waiting system, and you have no right to be assessed. You've got 100,000 people sitting waiting to get assessed. And if you're assessed, no right to get services. You could sit on the list for 6 to 12 months. And once you get the services, no right to get the services you can afford to pay for through co-payments. And if you don't get those, all the rest is rhetoric. And I argued at the Senate inquiry into into the aged care service delivery that consumers' co-payment should be capped at 10% of fortnightly income. And what we're seeing are people on full pensions being charged $300 or $400 a week and literally choosing between a shower and a meal. But what we're also seeing is a lot of people declining services because they can't afford to pay the consumer contribution. And that is such a false economy for government to think that people dropping out. I know that there's going to be people in central agencies counting the numbers and thinking they would count that as success. What we already know is that those people will be going to the GP more often, getting more medications for stress and anxiety, ending up in emergency departments, hanging around in hospital beds, and then becoming progressively deconditioned and ending up in residential aged care. And it is completely mad to cut back on the services where an investment saves costs upstream. And unless we can get that, unless government starts to that is the only basis by which we will get this system redesigned, is when governments work out that they have to invest early and make that easy and accessible. There should be no wrong door to primary aged care, just like you go to the GP. If you think about the billions that are being spent to get primary medical care, to 90% bulk billing and urgent care centres, that is not because government's just benevolent about doctors. It's because they actually understand that's what delays or prevents you needing more expensive services. We have to adopt that same approach. We don't have the residential aged care services to accommodate the boomers, and we taxpayers can't afford to do anything but.
So, Kathy, I think it's by unanimous demand, everyone here at our All Things Aged Care Community of Purpose would love to have you come back more regularly. It feels like we have a number of instalments to go to really capture all of your thoughts and insights and encourage the type of dialogue where change can actually take place. Kim, we thank you that you're always committed to that. I know there was one bombshell that you really wanted to share with our general listening base, Kathy, which is what's the numbers of our ageing population, the boomers, by 2035? If you can leave us with that thought of how we had to provide.
Yeah, so in 2035, so just go back a bit, 1945, all the soldiers came home from the war. And in 1946, they had a prolific large number of children, and those children are 80 this year, and there are 65,000 of them turning 80 this year. The last decade, about 20,000 people a year have turned 80, but this year, 65,000. In 9 years' time, 2035, there's going to be 2 million people over 80, and hundreds of thousands of people over 100. And the growth rate for the over 80s is 60% increase in the decade, which is more than twice the growth rate of taxpayers.
Wow. So with that bombshell in mind, try and sleep tonight, but we have got a real challenge on our hands. As always, an absolute pleasure. Kathy, thank you for your contributions and everything you do for ageing Australians.
Thank you.
Kim, you're always welcome back. We're going to raise the roof for Professor Kathy Eagar, all of your team, your esteemed colleagues at the University of New South Wales and the great work they do. We have a special hello from Paul Sadler and Mark Sewell, your colleagues in arms on the bed
blockages on that front.
Yes,
Kathy.
in Illawarra, we're doing a big 30-second boost where Paul and Mark and I are working together with Nikki Slug and a number of others looking at the health aged care interface in our region. Last week, over 20% of all our public hospital beds were full of people trying to get into residential aged care. So they were in our medical beds. The medical beds were the surgical beds were full of medical patients, and there was almost no one got elective surgery. This is a system-wide, a community-wide problem, and anybody who still thinks that this is a problem for old people has got rocks in their head.
Well, we'll pick that up on certainly next one. I think there's so much to continue to unpack on this subject. But Kathy, thank you again for your time today. Thank you for the audience and everyone's fantastic questions. Kim, lovely to see us out again from Townsville. And until next time, this is All Things Aged Care. And Owen, bring us home.
We always say, all for one and one for all things aged care.
Aged care. Bye, everyone.